So we'll go on to pediatric TB. What's new? Lots of things are new. And anything new is a challenge. I think this hospital knows that anything new is a challenge. So we have diagnostics that are new. That's a challenge. We have treatment that is new. There's so much new in treatment. That itself is a challenge. Prophylaxis, latent TB has become a challenge because there's so many regimens that have now come. So that itself is a challenge. So we'll take one at a time and see how we can see the challenges. Now, if you look at challenges in diagnosis, I remember as a resident how we used to diagnose TB. We would say fever, cough, cold, MAN2 positive, Cox contact, this is TB. And we used to start TB treatment. Very simple. I mean, those eras were really uncomplicated. And as more and more diagnostics came, and we became more and more complicated diagnosis. Now you're in the molecular era. So you have nucleic acid test, especially the gene expert. And then you have pyrosequencing to even make it more complicated. Then you have these, instead of MAN2, now you're doing IGRAs, the quantiferon TB-Gold. Then now you have a Psi-TB test. The Psi-TB is just like your MAN2 test, except that the antigen is different. So this is available in the program. And you can do it in adults. So any family member, you can do Psi-TB and look for latent TB. Then in immunocompromised, you have a urinary LAM test. So again, that is something that has come up new. And now, future-wise, we are going to go into the AI system. So we'll have a lot of AI telling us this is TB, this is not TB. Especially if all of us have been using ChatGPT, which my students educate me about ChatGPT. Madam, ChatGPT mein ye likha hai. So he is actually telling us ki this is what you are supposed to do. So we'll be into an era where we stop thinking and we just follow the command from the AI. So even the algorithms for treatment have changed. As I told you earlier, we used to just say clinically, TST, chest X-ray and treat. Now we are going more and more targeted. We have to get a microbiological evidence. We have to do gastric lavage. If not gastric lavage, we have to do bronchoalveolar lavage. So more and more invasive we become. And then we started doing ultra upfront. That's in the guideline now, which says that the moment you suspect, you do an upfront ultra or an expert. And then very rarely we actually make a diagnosis of clinical TB and we start treatment. We actually prove it's TB because we are in an era of drug-resistant TB. So you also want that diagnosis. When I started the TB clinic at Wadia in the year 2007, we used to hardly see drug-resistant. So in fact, we were not ready to start a separate TB OPD. It was part of general pediatrics. And then we said, no, there's drug resistance that's increasing. So in those times, we used to see drug resistance to the tune of 3%. Then gradually it became 6%. Now it's 10%. Now it may be even further going up. I've stopped calculating now how much percent of drug resistant TB. So you want to know the drug resistance pattern, and that's the reason why you're going more into invasive testing and molecular diagnosis. Now, algorithm for TB has become more and more complex, though they are trying to make it more easier. But if you look at this, I don't want you to look at this. I've just displayed it so that you know that it's not that easy to diagnose. And ultimately, it always comes down to, okay, if you didn't get a gene expert positive, then make a clinical diagnosis and you start treatment. But the most important thing is this part, which is the upfront gene expert that you should do in these patients. Now let's come up to these so it looks very good on paper that you do a gene expert, get a treatment, and you get a result. Problem number one, you do an ultra and you get a trace result. That trace result, which gives you RIFA indeterminate, I'm sure you all are doing ultras or you're doing. So if you do an ultra and you get a trace result with a RIFA indeterminate, first and foremost, you don't know whether this is TB. So gene expert all the time does not mean TB. If you have a trace result, you don't know how to interpret it. I recently had a child with Crohn's disease and I did a colonic biopsy. On that biopsy, I sent a gene expert ultra. And that came trace RIFA indeterminate. And the histopath showed me crypt abscesses, cryptitis, everything like a Crohn's disease. Now we are in a dilemma. What to do? Whether you give TB treatment or you give Crohn's disease treatment. So sometimes these tests can confuse you. And the program will definitely tell you do a repeat biopsy. It's not that easy to do a repeat biopsy. So I'll just go through this case. Now this was a 10-year-old girl, and she came with loss of weight, fever, and loss of appetite. And because of that fever, they kept on investigating her, and finally a CT chest was done. And that CT chest showed multiple lymph nodes. And ileal thickening was also there. So on this clinical suspicion of TB because of lymph nodes, necrotic nodes and ileal thickening, first line AKT was started. This was in March 2024. Then what happened? She continued to have fever and she started getting joint pains. So basically the hip pain which was radiating from the hip joint to the thigh. So other causes of fever were ruled out. She was referred to us for further management. We didn't have a diagnosis of TB. We just assumed this was disseminated, no microbiological evidence with persistent fever. And when we saw her, she had a gibbous. And she had a doughy abdomen. So again, going more towards TB. And nowadays, one thing that I've noticed is, especially the younger generation, when they present a case to you, they tell you, he came with these complaints, on investigation we found this. And I tell them, what is the examination finding? And the examination finding has gone for a toss. So his investigations, you see there's lymphopenia there, the ESR is high, CRP is high, uric acid is high, but nothing otherwise very significant except for that gibbous. Now, investigations-wise, we send a gastric lavage. At Wadia, we also do a stool gene expert. I'll be coming to that later. Chest X-ray was normal. Abdominal ultrasound showed omental caking, so again going towards TB. And then an MRI was done. And you are seeing this MRI which has got multiple vertebral involvement. And there is pus formation. So you're thinking, is this malignancy? Because TB reports are coming negative. Or is this drug-resistant TB? So what should we do in such a scenario? Should we just continue AKT? Anybody? Okay, so we can do a biopsy. So this is what we did. Because we had an omental caking, we decided to do the least invasive way. So we did an omental, we did a laparoscopic, and you can see these nodules on the mesentery. And this time, the histopath was classical TB, and the gene expert showed M.Tb, which was RIF sensitive, rifampicin sensitive. You have a child who's been on 1 month first-line AKT, and still the rifampicin sensitive report. So it's not drug-resistant TB. So why did this TB spread?
Associated HIV?
HIV is negative. You've given the proper treatment, you've given first line, the TB still spread. Now the answer lies in the 6 with MGIT culture. The MGIT culture is negative. That means there is no actively growing bacilli. The gene expert is a PCR based test. So it can even pick up a dead bacilli. It doesn't tell me live versus dead. So this tells me that the bacteria is dying, the culture is negative. But the disease has progressed in the form of clinical fever is done. This is known as something known as paradoxical reaction, which in HIV we call as IRIS, immune reconstitution. So it's something like an immune reconstitution where you start the patient on treatment. With treatment, the patient has an immune reactivation, and that immune system is causing the disease to get fever or increase in the nodes or increase in pleural effusion. So what you see is this, that there is worsening radiologically or new lesions developing. And usually you would see them as lymphadenopathy or tuberculomas or pleural effusion. Here you saw these nodes that were coming up. But the TB is actually dying. It's just an immune reaction. So the treatment here would just be steroids. You just continue the same drugs and steroids would be the treatment. But then everything is not TB. And we come to a second case. This was last month. This child is 13 years old. She's had generalized abdominal pain for 7 months. Since last 1 month now, she's getting breathless. She's having fever for a month. She's got low back pain, weight loss. She's been on first line for 5 months. And this child, when I first saw, this was the outside report in February, where they had started TB treatment again clinically based on these necrotic nodes in the neck, in the abdomen, and if you see the CT also, the CT report by the radiologist was Cox etiology. So the other challenge that I face is interpreting a radiology report which has been reported by the radiologist. Okay, that's another challenge that you face because you have a radiologist who said this is TB and you've started the treatment based on that report. So a lot of times I'll end up doing endoscopies because the radiologist says there's evidence of portal hypertension. But when you put in a scope, there's nothing. So this was again in June. She was started on first line. You can see that she's lost weight now. Her fever subsided, but everything else remained. Sputum gene expert negative. Again, USG abdomen. Nodes are there, but no necrotic changes now. And again, mild omental involvement. So her ATTs continued. When she came to us, the most important thing that struck me that why is there a popliteal involvement? There were nodes in the popliteal region. We don't see TB like this. We don't see TB with inguinal nodes. Yes, supraclavicular, all that is there. But you don't see TB like this. So this is something that made me think, oh, this is not TB, maybe something else. So anything else? Okay. Yes, Hodgkin's lymphoma. So if you look at this, we did a sputum, stool, urine, inguinal tissue, everything gene expert came negative. And you see her X-ray, this is her February X-ray and this is her August. You can see these shadows that have now started coming. USG abdomen, you see all these changes that are there. Basically, she's got necrotic, again it's reported as necrotic nodes. And she's got psoas abscess involvement. And then she has inguinal region also, again, necrotic involvement. Her MRI spine is again showing a lot of pus all over. So again, the radiologist told me this is TB. But when the histopath came for this child, the histopath was Hodgkin's lymphoma, when we did an inguinal lymph node biopsy. So the other challenge that you will face is clinically you may not think it's TB, but somebody from the radiology will tell you it's TB, and then you will go on a wrong track. So always better is to talk it out with your radiologist consultant. And when we talked it out, they actually looked into the films more deeply and we realized that this is not TB. Then they said this is malignancy. So this is one challenge that you would face with newer diagnostics coming up. You will have to get into an era of talking to people. So this is an art that we've forgotten and we have to come back to that. What we in Gujarati call as panchat. So you will have to do panchat. Okay, so we are in an era of microbiological diagnosis of TB, NAT, MJ, pyrosequencing. Again, there are problems with this. Sometimes you may get pyrosequencing giving you a different report, and you'll get a gene expert giving you a different report, and then you don't know how to interpret those reports. The other problem now, earlier we used to do gastric lavage, we used to do bronchoalveolar lavage, induced sputum, maybe expectorated sputum. Now you have new specimens that you can do. You can do stool, you can do nasopharyngeal aspirate. We have a study that is going on at our center where we are looking at mask. So these patients breathe into the mask, and that mask is tested for TB by the PCR. And we are getting into research for even tongue swab. So where tongue swab is taken and we look at presence of TB because ultimately it's expectorated. So these are two in the research mode, but what is now WHO recommended is nasopharyngeal aspirate and stool. So I don't think in Mumbai anybody is doing stool at the moment because it's not in the program. But we've started doing at Vadia, and I will show you that data also. So from 2020, WHO has recommended stool. It's easy to do. The problem why it's not there in the program is it's not very standardized. There are lots of methods to homogenize the stool sample, and not all labs are up to it. So you need to have your lab which has standardized that procedure of concentration of the stool. Then only you'll be able to do this test. And what is useful as per WHO is it's useful in children less than 5 years, and it's got sensitivity of 50 to 70%, which is compared to the culture. That is what they have said. Now, the limitation is it's got lower sensitivity than your respiratory, that means your BPalM and GL. So you will not be, if you get a stool gene expert negative, you still can't say this is not TB. You will have to do a gastric lavage or a BAL. And as I told you, the homogenization is an issue. Your lab has to be really standardized to have a standardized protocol to do this. So if you look at this GL, stool and induced sputum, so among the the stool has a lesser sensitivity as compared to GL and gastric, this thing. But gastric aspirate, you need to put in a tube, the patient has to come to the hospital or to the clinic, empty stomach, and then you have to aspirate. So it's little invasive, it's not very conducive. Induced sputum, you can't do it in a closed room. You need to have a room which is very well ventilated. At Wadia, we do it at open air. So I make the patient sit outside. And outside the clinic, outside the OPD, in open air, because there's a lot of aerosols that take place. So you need to be very careful about that. So stool is very easy to collect. They can get it from home also. They need not get the patient. Now this is our data, and this was just published this year. Meenakshi has also been a part of this study. And we had 52 children. 30 had positive pulmonary expert, so either BAL or GL. And 17 had a positive stool gene expert result out of these. The most important was, okay, the sensitivity and specificity was very good, the sensitivity was not that great, which even the WHO data tells you, it's not that great. But what we found is that stool expert was equivalent as pulmonary expert in children less than 5 years, okay? So 4 children each less than 5 years tested positive out of 11 in both the groups, the pulmonary as well as the stool. So it was quite equivalent. And there have been, in this study, we also found cases where sputum was negative or GL was negative and stool was positive. So we could do, so now what we do at Wadia is we land up doing both actually. We land up doing, so we get a better yield. So this was our data on stool gene expert. So we do this routinely as stool gene expert. And we've had a very good outcome because a lot of patients, even for intestinal TB, I avoid a colonoscopy a lot of times because I just send a stool. And if it comes positive, I don't need to do a colon. Any questions?
So easy.
Yes.
If it is, but all it has to be done.
Yeah, your lab has to be capable enough to do it. So it may serve as a supplementary diagnostic, not as an initial diagnostic. It may serve as a supplementary because it's got a lower sensitivity as compared to pulmonary samples. So no standalone stool gene expert. Now nasopharyngeal aspirate, I actually have no experience on this. This is all bookish knowledge. So they say that it's supposed to be sensitive enough, specific enough. But again, WHO says that you use this only when as a multiple specimen strategy. It's not to be a standalone test. So you can't do nasopharyngeal aspirate standalone. Either combine it with GL or combine it with stool. So that's your WHO itself is saying that you will have to do not as a standalone test. I don't think anybody really wants to do nasopharyngeal aspirate for TB because we rather do if we are going to do an invasive procedure, we rather do a gastric lavage. So we had challenges in specimen collection and diagnosis. So we have more questions than answers. Is that correct? Or we've got more answers. I think the more we evolve, the more complicated life becomes. And common sense is something so uncommon that we've forgotten to use it. Okay, so we go on to challenges in treatment. Now, what is the regimen that you all are following? So 4 HRE. Yeah, so 2 HRZE and 4 HRE. And if you have severe kind of TB like TB meningitis or bone TB, you extend it for a year. That's the standard therapy. But people are not happy with that, no? They want to come out and make things more complicated for us. So this is our standard therapy. Now, India has E in the program. The rest of the world doesn't use E. And why is E in the program? Nobody has an answer to that. Okay, so the excuse that we have is because INH monoresistance is too high in the country. So to prevent single R therapy in the consolidation phase, we are giving E. But the data that is coming out is quite different. So right now, this is the therapy that we form. Then WHO comes out with, no, 6 months is too long, we need to give shorter. So they come out with a 4-month regimen. So 4-month regimen is HR, ZE and HR. But which patients? Non-severe. So first you have to identify what is non-severe. Then they have also come out with a 2 months drug-sensitive TB of INH, rifampicin, moxiflox, pyrazinamide. So this is a regimen for 12 years and above. I fail to understand this regimen because I would rather say moxiflox for drug-resistant TB. Okay, so this is another regimen. And for meningitis, they've come out with a 6-month ethionamide-based regimen. So we would straight away give, instead of ethambutol, 6 months of HRZ and ethionamide. This is based on South African data. So fortunately, we...
Means all 4 drugs?
For 6 months, yeah. So fortunately, we have clever people in the guideline committee. So we've not implemented any of these till now. The reason I'll come to you. One is the first one. We go on to the 4-month drug sensitive for non-severe. Now, non-severe, what have they defined? Peripheral lymph node TB, mediastinal TB without airway, pleural effusion, and non-cavitatory lung TB to the one side of the lung. Now, to have this kind of a regimen, different regimens for different age groups, different varieties of TB, you need to have a proper education of doctors, nurses, PHC officers, everybody. And then 6 months later, guidelines will change again. So again, we go back to educating them and confusing them more. The problem is this, when you have these severe TB, and what do they define as severe cavitatory TB, bilateral TB, pleural, and then extrapulmonary like meningitis or anything. Where does paradoxical reaction come here? I may start with the lymph node TB, but if the child has a paradoxical reaction, which I showed you in the first case, where would that come to? So that is one thing. Now, if I decide, okay, I'm going to give only 4 months, how do I decide end of therapy? What do I monitor to decide end of therapy? So they come out with these guidelines based on non-inferior trials. So they don't say that it's worked very well. They'll say it's non-inferior to the standard regimen. So it's very cleverly worded. So till now, these things that 4-month therapy, we can't implement it till we get more information from our country. How are we going to do that? Now, if you look at this mediastinal TB, they say that isolated mediastinal TB without airway obstruction, 4 months is enough. Our study on mediastinal lymph node TB, average duration of TB treatment was 11 months, not even 6 months. Because if you keep on doing their CT scan, you still find that node is there. Are you going to leave it alone? Until it calcifies or it disappears, you're not going to stop treatment. So this is our average. And if you look at paradoxical reactions out of these, it's almost 3%, 0.3%. So you have to be very careful about, these 4 months therapy. Now I'm coming to this paper. This is a very old paper, 2021. Now you can see duration of AKT in patients who had radiological recovery was, what did I mean by radiological recovery? The tuberculoma has calcified or it's remained the same size, it's not increased, there's no perilesional edema. So all these things tell me there is a radiological recovery. And then you can see even in those patients, we had to give it almost for 15 months. So even in TBMs and tuberculomas, you'll have to keep. And those who are not getting radiological recovery at 12 months, we've given them almost for 1.5 years. Okay, so be very careful. Don't stop unless you see a radiological response. And this is our data on ethionamide and ofloxacin. So we've used 5 drugs in these patients. So we started with five drugs and then come down to HR, Z, and ethionamide. And what we found, overall duration treatment, again, it's the same as that for the standard regimen. So you still need But what was the difference between the two regimens is the amount of morbidity. The morbidity was much less with this, the sequelae, the hemiplegia, the learning disabilities, all that, vision problems, all that was much less with this regimen. But the duration didn't change. The duration had to be this long. So again, the reason is this incidence of tuberculomas that develops in them. So this is a better regimen, ethionamide base, still not implemented in India, but again, not for 6 months. You will have to see a radiological response and then take a call. And don't forget, paradoxical reactions also require extension of treatment. So this was the paper in Paradoxical, and our incidence was 3.3%. So this is one thing that we have to keep in mind, that even DS-TB requires close monitoring. Extension of treatment may be based on response to therapy. Let's see this. You have a 12-year-old female. She's suffering from nephrotic syndrome for a year. She's had vomiting for 5 days, and then she comes with a right upper limb monoparesis and difficulty in speech. So she comes with a monoparesis. And an MRI is done. There are infarcts, which is expected. But what is there is this granuloma. And the CSF is normal. There is only one lymphocyte. CSF Ultra does not pick up M.Tb. So we searched for TB elsewhere because she's immunocompromised patient, she's nephrotic syndrome. So we did an HRCT, and that has shown these nodes, which are there. I have not put the other film, but there are nodes there. And there are consolidation in the lungs. BAL is done, M.Tb on Gene Xpert, rifampicin sensitive. So she started on first line AKT. Now after 6 weeks, the MGIT culture comes from the CSF. Her Gene Xpert in CSF was negative, and now her MGIT culture comes. And that, you see, has shown a pre-XDR pattern. It's resistant to INH, rifampicin, quinolones, and pyrazinamide. So you have drug sensitive on BAL, and you have drug resistant on CSF. So now you're in a quandrum what to do, how to treat this patient. So why is it showing this kind of, pulmonary is showing rifampicin sensitive, CSF is showing pre-XDR pattern. What would you do? And this is very common. We get this quite common, and you have to rack your brains what to do. ChatGPT cannot help you here. So what should we do? How should we treat? Okay, so one thing I want to tell you, that the pre-XDR drugs, they don't work very well for rifampicin sensitive. So INH, rifampicin, pyrazinamide are bactericidal, whereas all the other drugs are not that great. So this is when a patient gets infected by mixed strains. So there may be dual. You have an immunocompromised patient. So just as you have polymicrobial infections in immunocompromised, you can get poly-TB, yes, heteroresistant. So this is mixed strains. And this incidence is pretty big. It's not unusual. So you have to talk to the lab when you get this kind of report. Say, for example, last week I had a patient where we did bedaquiline testing. Bedaquiline is a new drug for DRTB. And bedaquiline, when I did the testing, it was a psoas abscess. So they took one from the psoas muscle and one from the abscess. And the lab reported the abscess as bedaquiline sensitive and the psoas muscle biopsy as bedaquiline resistant. So this is a lab error. So you have to go back to the lab and talk to them. It's a manual error of writing or typing. So when you have this kind of mixed resistance, first confirm with your lab. Have they given you the right report? And once they've confirmed, then if you have a mixed infection, then you have to treat for both. You'll not only be able to give drug-resistant TB treatment because it doesn't work very well for drug-sensitive. So in this, you will have to treat with both first line and second line in these patients. So here we give INH rifampicin, and the second line drugs were PAS, clofazimine, bedaquiline, delaminate. So this was our combination that we used in this patient.
So 5 drugs then?
6 drugs we used. Anyway, when you have MDR-TB, your regimen is minimum 5 drugs.
And then you give this for as long
No.
as that?
You have to again monitor.
As long as you get a radiological.
In this patient, probably I would look for bacteriological also. Yeah. Because I have an immunocompromised patients, mixed infections. So I would want a bacteriological evidence before I stop. So TB diagnosis and treatment is evolving. Disease progression is variable on treatment. That's the conclusion. And I think I've confused you all enough.
No, we got none of it.
You got the idea, it's challenging.
And that we can't stop the treatment. I think that was a take home for us,
Yeah.
clinical practitioners.
Yeah.
Cannot stop before. What is the new thing which has come 3-4 days back in the times of India? That now the MDR tuberculosis, you have a 6-month regimen.
Yeah, so I'm coming to that. So you have a DRTB, there are new guidelines that have now come in March. So TB is something you have guidelines coming every 6 months. So you need to keep yourself updated and get more confused and then go back. So what I do is when these meetings are there, they always land up saying there's no Indian data, so let us adopt the WHO data. So then I'm in a rush to publish our data and fight it out with them. Like Stool Gene Xpert, I was in a rush. So publish it. Then even these new regimens that have come. So these are the various types. Just remember MDR-TB, HNR resistance is what we are looking at, and pre-XDR is with a quinolone additional. So this is what we are looking at in resistant TB. And you have various groups of drugs, but the new drug that has now come is bedaquiline, and you have delaminate. These are the 2 new drugs that have come. So these are the various drugs, various classification also keeps on changing, the grouping of the drugs keeps on changing. So for MDR-TB, you have a BPalM regimen, then you have a shorter oral TB regimen, then you have a longer TB regimen. Very simple, I'll make it in Mumbai and Thane and Kalyan, suburbs of Mumbai. This doesn't work. Shorter oral, okay? So we have patients predominantly on longer oral because we have so much resistance. It's not only INH rifampicin. We are seeing resistance to pyrazinamide, ethambutol, ethionamide. So this regimen doesn't work. So we have for 14 years and above, so that doesn't come to us, it goes to the adults. So for children, this is the regimen that you have to follow, the longer oral regimen. So I'm going to skip the slide on the BPalM regimen completely. And just remember the BPalM regimen had linezolid at 600. Now, very high, once a day. Linezolid is a drug, one, save it for TB. Don't use it for your pneumonias. Save it for TB, that is one thing. And linezolid, you will have lot of side effects. 2 side effects you have to remember with linezolid: anemia and peripheral neuropathy. And the peripheral neuropathy is so bad, they can't walk. So these 2 things you have to remember. Now this child came in February. He had fever, wet cough, all these symptoms for TB. And they diagnosed miliary TB, they started TB treatment, MDR-TB regimen, he was rifampicin resistant. April, 2 months later, he developed burning sensations in the soul. So he had peripheral neuropathy. You can see this regimen, bedaquiline, linezolid, cyclosin, flufa, all that. And then when he gets this, they stop linezolid. Okay? But he still keeps on getting excruciating pain. He's got anemic, he requires blood transfusion. Then he comes to us in mid-May and he's got severe pain. He's just not able to sit or walk or do anything. We do a NCV and there is a sensory motor neuropathy. And then because cycloserine can also cause this problem, his cycloserine was also stopped. So we stopped this also. And we replaced with delaminate and PAS. But what is important is, imagine what all he required for his peripheral neuropathy. He required pregabalin, gabapentin, morphine. That's severe pain. So be very careful when you use linezolid. So when we sent him home, by day 10 we could reduce his pregabalin and morphine. But he went home on all these, gabapentin, duloxetine, nortriptyline, everything. He's still falling up. He still walks. They can't wear chappals also. So he walks very, very carefully. They have kind of a high steppage gait. They walk that way. So DRTB regimen, two things. Extensive monitoring for adverse effects, and some adverse effects can be fatal and sometimes irreversible. You can pick up a patient of DRTB, that this child is on TB treatment, MDR. The moment you see red skin, you know this child is on DRTB treatment. Clofazamine. Clofazamine has this cosmetic, it makes your skin red. And it's so red that they sometimes ask you, will this ever fade away? And we say, yeah, over a period of years, it will become less, but it won't go away. No. So like HIV, you could make out a patient on HIV treatment, they would have this lipodystrophy. So you know the cheeks have gone in, you know he's on ART. Similarly, like all these people nowadays have this weight loss medicines. And you see their face.
Yes.
That's exactly the face of ART.
Yes.
So that's the kind of lipodystrophy you get. Similarly for TB, MDR TB, if you see that red skin, you know the patient is on clofazamine. Now Mantu, you want me to continue or shall I stop?
Please continue.
I want you to continue. It's 47 minutes. Okay. Latent TB, we all talked about Mantu. Now we have come to IGRAs. And now we have come to Psi-TB. Psi-TB is just like Mantu. The antigen is different. It's very specific for M.Tb, ESAT6 and CFP10. So it will detect only M.Tb. It will not give you a positive result with BCG or any other atypical mycobacteria. The Psi-TB test right now in the program is only for adults, those more than 18 years. So it's not available for children. So for children, we have gone to QuantiFERON TB-Gold. There are two types of QuantiFERON TB-Gold. You have Gold and Gold Plus. So when you ask your lab, be very careful of what you are asking. This is a third generation test, this is a fourth generation test. And the fourth generation test looks at response. The first one is for the CD4, the older one. This one looks at CD4, CD8. So what it looks is recent TB exposure. You don't know when this TB occurred, but the CD8 test gives you recent TB. But you have to know how to report this test. Okay, it's a difficult way to interpret because you have to look at the ratio of CD4, CD8 in the test and report it. And it's more expensive than the Gold Plus. So we stick to the Gold Plus test, most of the labs. There are some labs who do the Gold Plus, which is, you need a way to interpret it. Now when we had done this QFT versus Mantu, I wanted to show you this data where we had compared tuberculin skin test and why it got replaced. Because with tuberculin skin test, we were picking up a lot of false positives. Mantu positive, false positives, BCG. So if you look at this, you have Mantu positive in 5, but it was negative by IGRA. So they were false positive. So this was the thing that helped us when we were doing both. And now we've stopped doing Mantu completely. How many of you all still do Mantu? Okay, there are some labs which still offer you Mantu. So remember, if you do a Mantu, do it with 5 TU, not 10 TU. So that
We do
2 is not available. We have 5 TU PPDS and you have 2 TU with RT twin AT. That's the detergent. So if your lab is doing twin AT, then you use 1 or 2 TU. But if it is using PPDS, then 5 TU. It's not available. It's what we get in Mumbai is basically PPDS. So that comes as 5 or 10. Then they do with 10, then everybody comes false positive Mantu. So latent TB drugs which we were using, 6 months of INH. Again, life should not be that simple. So it became 3 months of rifampicin INH. And then it became 3 months of rifapentin isoniazid. And HIV, I have not put the slide. HIV is even different regimen. I still stick to this. Why? Because I don't want to use up rifampicin. If that latent TB goes to active TB, this person is going to get M.Tb. So I prefer, okay, monoresistant chalega, but not MDR. So this is what we do.
Stick to the last one.
Rifampicin is also rifamycin group.
So only the
You can stick to anything that you are convenient with. This is just a personal, yeah. For me, why they came with this regimen is, why do you want to give 6 months therapy? So they said we want to shorten it. To shorten it is, this is the reason that they came out with this regimen and lesser hepatotoxicity. I really haven't seen 6 months of INH giving any hepatotoxicity. It's only when you give combinations that you get hepatotoxicity.
Any duration between exposure and when we order IGRA? Like I had recent one patient, the grandmother was a known case of ILD, got TB, and they came to us, and by the time they follow up with the report, the grandmother expired. Luckily the child was negative, asymptomatic, growing well, and it's a 1-year-old child, 1.5 years, so negative, still on follow-up close. But then anything like duration of exposure, how long?
So in this kind of a scenario, you may have to put them on prophylaxis, because even though the child IGRA is negative, there is a very high chance that the child may be still harboring latent TB. Even in, say for example, you have a child who's open TB and you're screening the parents. Today you screen them. 3 months later you'll do a repeat X-ray in the parents. Because they may still be having, yeah. So you may have to have a close follow-up to decide how long you want to keep on monitoring them. But in that child, you will definitely need to, less than 5 years, you will have to give.
Even though negative.
Even though negative. So these are the doses. I'm not going through, you can take a photo if you want of these weight bands. So the key message finally, the key message is TB has changed a lot in few decades, and diagnosis has become more evidence-based with microbiological. Treatment is more complex, more difficult, and with evolution comes the challenges. Thank you very much.
Thank